Hello and welcome. I'm Steve Clemons, editor-at-large of The Hill. Thank you for joining us for a timely and important discussion on diabetes and the COVID threat. The coronavirus pandemic is presenting new challenges for the 34 million Americans living with diabetes. According to a recent report from the Centers for Disease Control, those with underlying conditions such as diabetes are 6 times more likely to be hospitalized and are 12 times more likely to die as a result of contracting COVID-19. And communities of color are once again disproportionately affected because of underlying socioeconomic and health disparities. This is a real big problem. We will spend the next hour examining issues of access to quality care when physicians, health systems, and hospitals are stretched way too thin. We will ask what policy priorities need to be put in place to ensure that diabetes management tools and resources continue to be available, especially for those who need it most. Will telemedicine remain a viable option for all patients? That's a big question. And how do we ensure treatments such as insulin and devices designed to test blood glucose are both affordable and accessible to those who really need them? And there are a lot of people who fall through the cracks. I'd like to thank our sponsor, the National Diabetes Volunteer Leadership Council, for their support of today's event. We have a fantastic lineup of speakers to help us get the information we need. Doctors, policymakers, and experts who are closely studying racial disparities in healthcare. We also have 2 members of Congress joining us. Before we get underway, a few housekeeping notes. You can tweet us at @TheHillEvents, that's @TheHillEvents, using the hashtag TheHillDiabetes. I had to get all that just right. We're broadcasting live and we'll be taking your questions throughout the program. My colleague Katie will be bringing them to me. As with any live stream, you could experience occasional trouble with the video. I've heard that before. It never works for me, but hopefully for you. Refreshing the page should, in most cases, fix the problem. My first guests are 2 people who know exactly where the gaps lie in terms of diabetes care. Dr. Ann Peters is the director of the University of Southern California's Clinical Diabetes Program. She runs diabetes centers in Beverly Hills and underserved East Los Angeles. Dr. Kerry Puchran is the president and CEO of the National Minority Quality Forum, a Washington, D.C.-based nonprofit. For years, he's been fighting to strengthen the capacity of local communities in order to eliminate the disproportionate burden of premature death and preventable illness in minority populations. Welcome to you both. Thank you so much for joining us. Let me just start with Dr. Peters and ask you for a moment. I mean, I think this is a really, really important topic because I'm looking out there right now at what's driving mortality in the period of COVID-19, and it's these comorbidities, these underlying conditions of which diabetes is huge. And I just was looking at data that was showing that many of the younger people that are dying, whether they knew it or not, have underlying conditions, and many had diabetes. So can you tell us what the map of these kind of converging diseases look like?
Well, often when people have diabetes, you're correct. They have more than one condition. So they often have diabetes, they're overweight, they may have high blood pressure and heart disease. And I am seeing a terrible confluence of all of these things in patients. I see younger people sicker who have diabetes. But again, it's often because all of these factors are at play. And then in the minority populations, they have less access to health care. They may have less good medications to lower their blood sugars. So they may not be in as good a shape at baseline as I hope they could be. And then when they get sick, they often have less access to us. So I really believe that people with diabetes can lower their risk of doing badly, but they need access to health care.
I think, before I jump to Dr. Puchran, what do people do? I mean, I think right now when you kind of look at this question of staying safe in these times, we've talked a little bit about telehealth, but I mean, is the answer really just to remain totally isolated?
Well, for a lot of people, they can't remain totally isolated because they actually have to go to work. A lot of the people I see are essential workers, and if they don't go to work, their family doesn't have food. So you actually have to balance it. And I think if the work environment is safe and if people wear a mask and do the right things, they can stay safe, but it takes some effort. But it remains that people need to keep taking care of their diabetes. And I tell people this is a great time to use telemedicine, to use whatever you can to connect to healthcare, because it's when people actually lose that access, then they can't get their insulin. All those things happen. And then diabetes becomes even worse, or at least as worse as COVID, because those two don't interact well together.
Dr. Puchran, decades ago, you blew the whistle on the fact that a lot of communities of color, were having disproportionate health impacts, that there was an inequality embedded in the system. What are you seeing? Fast forward, you've been working at this for many, many years. What has COVID aggravated in the conditions that were already problematic before?
So the challenge that we have with diabetes, even before COVID, if you start looking at the numbers, in the United States, certainly in the Medicare program, and we've seen it in Medicaid and commercial insurance as well, 60% of everyone with diabetes goes to the hospital every year on average, 60%. African Americans, it's about 67%. If you have diabetes and ischemic heart disease, you have a 90% hospitalization rate, 90%, right? And that's been going on for years. And we've had a diabetes epidemic in this country, and for lots of reasons, we have not addressed it. But we started doing our work, about 3% of the American population had diabetes in the year 2000. It's almost 9.5% now. And we have about 13 million diabetes-related hospitalizations every year. So you take that problem and you add COVID to it, and you can't be surprised that these people with weakened health systems go to the hospital more, die more from COVID. We have simply not taken on the diabetes epidemic in this country. There is no national strategy, no plan to actually take on diabetes. And it's a disease that is manageable. There is no reason why 60% of people with diabetes on average should be going to the hospital. In some zip codes, it's 70 and 80%. So that's fundamentally where we have to start at. We have to have a realistic understanding that this is a disease that we can manage, and we have to have a national strategy to do that.
Gary, before I leave you, I one of the areas which I've had some knowledge about, have looked at, have had colleagues write about, is the greater Baltimore area, and the staggeringly depressing statistic that you could go between different parts of greater Baltimore, between zip codes essentially, and have 20 years difference in life expectancy between those districts, which is just there. So I want to ask you maybe an unfair question. What are the three things that could most be done today that would help bend that curve a bit and begin solving some of these disparities? Is it just money? Is it resources? Are there other issues out there that we need to be aware of?
So we have a legacy health system that was built right after World War II. That legacy system was predicated on a tiered healthcare system that by its structure delivered inequality in healthcare. Oftentimes people say, because of poverty, you can't have access to healthcare. That's something that we created, right? And so the very fact that we can identify zip codes around the country where people's life expectancy is cut short by disease by 10, 15 years, that's something that we've structured. I mean, those are not accidental numbers. Those are numbers that are built into the system. And so part of the new normal, and COVID comes at this really interesting moment where we're having this conversation about equity and civil rights and simultaneously dealing with COVID. We have to have a new normal. We have to get to a place where we say that our healthcare system cannot elevate patient risk, that we can't have a healthcare system when people come into that system, rather than having the system reduce their risk, it's elevating their risk. And that's exactly what's going on right now.
Dr. Peters, I know that you are both a thinker about this and a practitioner, and I'm interested in diabetes and some of these chronic conditions out there, because these are discussions that seems to me we've been having better. How do we get on a better track to wellness? How do we treat those that are not getting the treatments they need? What are the gaps? Is there anything happening on the research front, on the technology front, that's a game changer that you see on the horizon for those suffering with diabetes?
Well, The actual fact is that because of the new treatments that we've had developed in the past few years, drugs called GLP-1 receptor agonists and SGLT2 inhibitors, they're medicines that not only treat blood sugars, they also reduce risk of heart attack, stroke, and kidney failure. So we have these wonderful new medications. And I actually don't even need new medications. I just need a system where I can provide these medications to everybody. And I've been working a lot in LA County, and LA County has a whole group that's been working on diabetes management for our population. And where we can get patients access to these medications, they really do seem to me to do better. So I have the medicines I need. I just need to be able to reach more people and more underserved people. Recently, with the Affordable Care Act and its Medicaid expansion, we've actually been able to help more people, but it's all about getting people access to the right health care. I have the tools I need. I just have to be able to use them.
What is the, I mean, is that gap you're experiencing one of cost? Is it one of trust? I mean, you can go to some communities who are going to be talking about clinical trials later in the program, and I've done a lot of programs on clinical trials around the United States, and sometimes there are social reasons why different groups, don't participate. But what are what are those barriers for you reaching those patients?
Well, it's complicated. This is not a simple question that you're asking an answer to, but
Great.
If it's hard to get health care for a lot of these people, it's complicated to get health care. And then people fall in and out of health care because they lose their job or they get a job, and then that changes their eligibility requirements. But we've been working in the same community for 20 years, and the people in our community are primarily Latino, and our staff is all from the community. And we actually don't have any trouble recruiting patients into our clinical trials or anything else because we actually, have people who speak the right language, but not just the right language in terms of speaking Spanish. They're culturally very similar. So you have to develop programs from within the community. The community has to tell you what it needs, and then you have to help the community in the right way. We can't just go impose what we think. I mean, I think one way. I live on the West Side, and I know the way we think, but that's different than these communities. So if you're very community sensitive, ask communities what they need. You can actually provide a lot of help.
Fascinating. Gary, I'd like to ask you a question, and then we have a question from our audience for both of you. You helped develop something that I've heard a lot about in the past, the U.S. Diabetes Index, and to creating an index around transparency and what's happening. I have not looked at this in a while, but what are the trends that you're seeing that our audience should be aware of today? And we know about COVID-19, but are there other dimensions of diabetes in this time about which we should be aware that you're seeing in your index?
The most frightening thing that people should know and see about the numbers is that they're getting worse, that the diabetes epidemic is increasing, that it's concentrated in minority and underserved communities, that it's very, very costly. If you look at the Medicaid program, it's almost 40% of the Medicare program. The underlying conditions are diabetes and are driving people in the hospital. I think, something that we need to think very hard and long about. If you listen to the COVID conversation about opening schools and opening back up the economy, it's this conversation about money and health. And as long as we prioritize money over health, we are going to have disparities. We are going to have inequalities because we're using money as a way to provision health care. And I would argue that that's not what we should be doing. That the most important thing that we should be doing is reducing risk for patients. And I think if we invest in that, there's a tremendous business opportunity, if you will, because we build our economy around our health. And I think that's a smart thing to do in the 21st century, and we're not doing it right now. We're just letting these numbers grow. The difference between diabetes and COVID is that COVID is killing immediately. The numbers, if you can see, people are dying, but diabetes is a lot more insidious. People die a lot slower, but it kills them nonetheless.
Well, I want to thank you. We've got a question from Marguerite. Marguerite?
My name is Marguerite Pridgen. I'm the Director of Federal Policy for the Corporation for Supportive Housing. Understanding that affordability and access to insulin is important, shouldn't more effort be made to address the social factors that contribute to diabetes in the United States? For example, in healthcare, full coverage of medical nutrition therapy. In government, contract preferences to suppliers of low carbohydrate and low glycemic foods. And in business, ending the strategic marketing of bad food to populations they know have higher rates of diabetes.
I think that question was made perfectly for both of you. Dr. Peters?
Well, so I'm a big advocate of improving lifestyle and health of the whole community. So one of the things our communities wanted were for us to help bring in farmers markets, which we've done, and help teach people how to cook with fresh fruits and vegetables and have a healthier lifestyle. And then we've done a study called Look Ahead, which is a lifestyle study looking at the treatment of type 2 diabetes with weight loss and exercise. And we've done it in our underserved communities, and our patients have done just as well as people around the country in much higher socioeconomic areas. So I believe we can do it and should do it. Lifestyle matters a lot, but there are a lot of people who have issues just affording food. We see a lot of food insecurity. It's easier to buy cheap, high carbohydrate, simple carbohydrate containing foods. There are a lot of issues around food, but I think it's a very important area for us to look at and work in, because if you can't eat well, then it makes diabetes even harder to manage.
Gary, can I piggyback on this question and just ask you to answer the question, but also to share with us if you've seen in your many years in this of how to kind of get people on a different track, counseling, education, the provision of foods, as Dr. Peters just said. Have you had any experiments or sort of small scale models that were promising that we should be thinking more seriously about scaling? Because, I think what Dr. Peters just said about the disparities in types of food and, the fact that you can, get that those that are financially challenged have a hard time, reaching these foods. But are there any examples that just shock you, that are bank shots that might help us move this needle forward on better health among the diabetes population?
Certainly, there's a body of literature out there that suggests we can slow up the onset of diabetes by diet and exercise. So that's clearly possible. There are also new technologies like CGM, continuous blood glucose monitors, that are doing really wonderful things in keeping people within a glycemic range that is having some impact on outcomes for people with diabetes. But here's the real issue, and it's kind of the thing that we talk about with COVID. There is no national plan to address diabetes. I mean, it's like nothing that is really saying, okay, this is a scourge in our population. We have to bring it under control. And how do we go about doing that? And we have a lot of tools. It's diet, exercise, it's technology, there's medicines. I mean, we can do this, right? But we have to have a plan. We have to execute. And in doing that, the priority has got to be managing patient risk. It's pretty simple stuff, and we're not doing it.
It's always simple things that we don't do, isn't it? I mean, there's so many things like that. And we haven't discussed wearing masks yet, but we could go a lot of different directions with this conversation. I want to thank Dr. Ann Peters, Director of the USC Clinical Diabetes Program, and also with the Keck School of Medicine in USC. Thank you so much. And Gary Puckren with the National Minority Quality Forum and the developer of the US Diabetes Index. Thanks so much for helping us to open this conversation and make it serious and thoughtful. We really appreciate it.